I'm a specialist in gynecologic oncology, which means Tom and I, we treat cancers basically that come from the vulva, cervix, uterus, and ovaries. Endometrial cancer is actually the most common gynecological cancer that we see. It's a cancer that comes from the lining cells that come from the uterus, the ones that are stimulated by the hormones that we have when we have periods. Women stand about a 1 in 40 chance of getting uterine cancer over the course of their lifetime here in the United States, so it's something that we see and treat quite often. The risk factors most commonly actually come from overproduction of estrogen or estrogen exposure. Having late menopause after age 52 increases your risk factor for endometrial cancer. If you've had no prior pregnancy. Things that can protect us from getting endometrial cancer are things that decrease the estrogen that comes into our body. And that's things like birth control pills, things like pregnancy, and maintaining an active lifestyle and a healthy weight. It decreases the estrogen that comes from our fat cells. One of the things that new patients with cancers always want to know, because we're women and we worry about our families, is this cancer genetic? The vast majority of endometrial cancer cases are not genetic, they are sporadic. Only about 5% of endometrial cancers are due to a hereditary syndrome called Lynch syndrome. The most common symptoms that women have that have endometrial cancer is abnormal vaginal discharge and postmenopausal bleeding. In terms of screening, we actually don't recommend screening for women that are asymptomatic, because as you saw on the slide before, about 90% of patients do have a symptom. So when you have a symptom, we recommend initiation of screening at that point in time. In terms of the diagnosis, we always perform a history and physicals. We like to perform a pelvic exam, and at that time we also do a pap smear and what's called either a D&C or an endometrial biopsy, which is a simple procedure that can be done in the office without anesthesia. So the next step in diagnosis and also in treatment of the disease usually is surgical staging. We basically perform a complete hysterectomy, removing the uterus and cervix. We recommend to take the fallopian tubes in both ovaries. This is what we used to do. In order to get to these periodic lymph nodes, we'd have to make an up and down incision that would come high into the abdomen. But probably now, about 95% of the time, we actually do these surgeries with what's called the robotic surgery with the Da Vinci robot. And with that, we basically make 5 small incisions that are all about 1 centimeter in size. Most people with this are only in the hospital overnight. I've had people back to work as soon as 2 weeks after surgery. So the benefits of robotic surgery were basically smaller incisions, which obviously leads to less pain, a faster recovery. And the most important thing that I think we should take from this lecture today is that perimenopausal or postmenopausal bleeding is not normal and should be evaluated, because you can see with the 5-year survival by stage, if we catch these cancers early, people stand about a 90% chance of living through their cancer for the next 5 years.